Hello and welcome to this episode of On Geriatrics. Today we shall be talking about delirium. Delirium is an acute confusional state. That means a person who's otherwise, has a usual behavior. From that usual behavior, if there is a sudden change in his behavior, where he is behaving a little abnormally, he's either very apathetic or he's become increasingly talkative or a little aggressive, or is a little confused about what is going on, then we suspect delirium. So acute here refers to something that has happened in the recent past, say in a matter of hours to days. It need not necessarily mean that it is something severe. It could be severe, it could be mild. But acute in medical parlance refers to something that has happened in the recent past, as opposed to chronic, which means something which has been going on for a very long. Delirium comes from the Latin word delira. De means off, and lira refers to a furrow through which a wheel travels, something like a rail, but the opposite of a rail, that there is a furrow through which a wheel travels. So the wheel has gotten off the furrow, so delira. So going off the rail in a sense is what is delirium. So why does delirium happen? So we must remember that delirium is not necessarily due to some problem with the brain in itself. Normally when somebody starts behaving abnormally, we tend to think that okay, something has happened to this person's brain, and we even try and start investigating in that direction by doing scans, etc. What has happened to the brain? But more often than not, it is not primarily a problem of the brain. It is just that the brain in an older person is much more vulnerable to any kind of stress than the brain of a younger person. So any kind of stress, be it a physical stress due to a recent illness like a urinary tract infection or a pneumonia or diarrhea even, can cause changes in the composition of the blood and can precipitate delirium. So it is important that we be alert to this. So if an older person starts behaving a little abnormally, is not his usual self even, then we must look for something that has precipitated it and not ignore it. Usually it will turn out to be some kind of an infection, and infections are most common the most common sites for infection are the upper respiratory tract or the urinary tract or the GI tract. Sometimes it can be due to a metabolic disorder like sugars going too high, or an electrolyte imbalance which was precipitated by the infection or by some new medicine that the person has been put on, etc. So we say in geriatrics that the disease manifests in the weakest or the weaker organ. It need not be in the organ of affliction. For example, as I said before, a urinary tract infection, the older person may not typically present with high fever, chills and rigors, frequency of urine, etc. Rather, they just become a little listless or starts behaving abnormal or become confused and become incontinent. So the cause is urinary tract infection, but the person is behaving abnormally. And if we are not alert to this possibility, we may start investigating the brain by doing scans, etc., or going in a wrong track. So why does delirium occur more often in the older person? One is, as we become older, our brain shrinks a bit. It becomes, loss of neurons will be there, and the brain becomes more vulnerable to any kind of stress. Older people also have multisensory loss. That means many people are visually impaired or they have hearing impairment. So they are a little bit cut off from the environment, and that also makes them more vulnerable for the delirium. People who are very frail, especially at the extreme of age, they are more vulnerable for delirium. Older people also tend to have multiple medical problems like diabetes, hypertension, heart disease, prostate problems, cancer, so many medical problems coexist, which makes them more vulnerable to any kind of a stressor. And people who have a pre-existing condition of the brain, like dementia, they are more prone for having an acute confusional state when there is a stressor. So what kind of stressors can precipitate delirium? Sometimes just a simple change in residence from one place to another, trying to adjust to a new environment itself can precipitate delirium, or loss of a loved one. Even conditions like acute conditions like a heart attack or stroke can manifest as delirium. Infections, as I told you before, or metabolic imbalance. When I said change in environment, sometimes we hospitalize an older person for some illness. Say, for example, it's a diarrhea and the person needs IV fluids and the person is hospitalized. It's a simple enough condition. So in such conditions, moving from house to the hospital can be a big stressor, especially the kind of environment that is there in the hospital, where people can be impersonal or lots of gadgets, and sometimes the person is cut off from the outside and is not able to discern what time of the day it is. That can precipitate delirium. Needless to say, any form of surgery or any stressful procedure that is done in the hospital can precipitate delirium. So how is delirium recognized? There is something, confusion assessment method, CAM for short. So delirium is characterized by an acute and fluctuating course. Acute means something which has happened recently or suddenly, and fluctuation, that is another very characteristic feature of delirium. You might be speaking to this person and he's speaking perfectly normal to you. Half an hour later, the nurse of the ward comes to you and says the person is behaving abnormally. So this change in the cognitive level within the day, within matter of hours, there are changes which happen. That is very characteristic of delirium. Inattention is a characteristic feature of delirium. A person with delirium, you will not be able to hold his attention. If you're trying to speak to him, his attention wanders all over and he'll be pointing to different things and talking about different things. He will not be able to focus on what you're saying. So inattention is a characteristic feature of delirium. Then the level of consciousness can be altered level of consciousness. Sometimes the person may be little stuporous, sleepy, or the person can have hyperarousal and be hyperactive. So that fluctuation in the level of consciousness, or the person has got disorganized thinking, is not able to coherently speak about a thing. That is another feature of delirium. Many persons in delirium have hallucinations. They report to seeing things, visual hallucinations, which are not there. This is as opposed to somebody with psychosis having more of auditory hallucinations. Although both can happen, but visual hallucinations is more in favor of delirium than auditory hallucinations. What are the types of delirium? So we typically picture in our minds that somebody who is delirious will be trying to jump out of the bed, pulling out the IV lines, etc., and becoming aggressive and talking a lot, blabbering, etc. But this kind of a picture, which is known as a hyperactive delirium, is seen only in 1/4 of the cases of delirium. In fact, the majority of delirium cases, as much as half of the delirium cases, are what is known as hypoactive delirium, which is where the person becomes very lethargic, quiet, not talking much, not responding. So you will mistake it that the person is just very, very ill. That is why the person is like that. But the person is sort of cut off from the environment and is in a state of hypoactive delirium, and this needs attention and needs to be dealt with just as with hyperactive delirium, because this carries equally, if not worse prognosis compared to plain hyperactive delirium. The remaining 1/4 of the delirium patients have a mixed pattern. Sometimes they are hyperactive, sometimes they are hypoactive. So that can also happen. So why are we so scared of delirium? Because delirium completely, in a way, derails everything, all your medical care and everything. The person is not able to take his medicines on time, is not able to cooperate with the rehabilitative measures, is not eating properly. So everything goes for a toss, and it will considerably delay recovery. And people who have gone into delirium, it also is not a very good indicator, in the sense that people who are more prone for delirium or who are developing delirium have a higher all-cause mortality in the coming year than people who do not have delirium. So delirium is something that we need to take seriously. So how do you evaluate delirium? When somebody has gone into delirium, look for the correctable causes for delirium which I had listed out earlier, and if you identify them, try and correct them as early as possible. Routinely, brain imaging is not required in delirium. Once you're reasonably sure that it is a delirium and you have ruled out clinically the possibility of stroke, etc., it is not expedient to go and get a imaging done, because that process itself can be stressful for the patient and can worsen delirium. In some cases, of course, imaging may be required. The doctor has to use his discretion. As with almost any other medical condition, prevention is often more easier and more effective than treating the condition after it has developed. So what are the preventive measures for delirium? Suppose a person is hospitalized. What would you do? You will try to make this person as comfortable as possible. The nurse in the ward, who is used to managing elderly people, will go and try to form a rapport with the person. And the person is placed in a well-lit place, close to a window, so that he or she can look out and see what time of the day it is. In the ward itself, in the visual field of the older person, you'll have a prominent clock so that he or she knows what time it is, a calendar to know what day or date it is. Equally important, make sure that if he is wearing glasses, give him those glasses so that he can see outside. If he is used to wearing hearing aids, make sure that he has his hearing aid so that he is able to hear what is going on around him. He should not be cut off. Then, once he is admitted, try to maintain as far as possible his normal routine. That is, what is the time that he reads his newspaper, when does he have his breakfast, when does he have his bath, when does he go to the toilet. Try and replicate whatever he was doing at home in the hospital also. To reduce his anxiety, keep somebody who is close to this person, a spouse or a son or a daughter, somebody who's very close to this person, with the person, for as much as is possible. That will greatly help the person to stay connected. Then make sure that the person doesn't go into incontinence. Sometimes just constipation and fecal retention and the discomfort that it causes may be enough to precipitate a delirium. Similarly, make sure that the person can go to the bathroom whenever he needs to, so that he doesn't wet his bed and lie on a wet bed, which can be stressful for the person. So these kind of simple things can make a big difference. So be proactive about asking for these things and making sure that the person is taken care of in these matters. And one has to be proactive in looking for any infections or imbalances, and they have to be managed promptly. Suppose somebody develops delirium, then what do? Basically, all the things that I just listed out in preventing delirium, all of them are also go a long way in helping a person recover from delirium. Please remember that there is no magic medication that can bring out a person from delirium. At the most, we have medicines to calm down the patient. Antipsychotics, Dexmed, etc. are used to calm down the patient, but we must remember they are calming down the patient, but in that process, because of their anticholinergic properties, they're actually cutting off the person even further and worsening the delirium. So you may be converting a hyperactive delirium to an apathetic delirium. So it's not about medicine, it is about how you take care of the older person. And as soon as a person is, reasonably recovered from his condition that brought him to the hospital, if he hasn't already developed delirium, plan for an early discharge. Once delirium has developed, as soon as you bring some kind of a control, and if he's otherwise okay for discharge, maybe an early discharge will help him recover from the delirium also when the person goes home and is in his more familiar surroundings. Of course, the discretion of the doctor matters here, and one should not discharge a person too early also without having properly addressed the medical condition for which he has come in. So that's all regarding delirium. Goodbye for now.